Okay, well, welcome to this episode of the Akkad and Koka Report. Unfortunately, Dr. Akkad, my erstwhile co-host, is unable to make it because he's currently saving a life in some cath lab somewhere. We have the pleasure today of having Ankur Gupta on today. Ankur Gupta is coming on to talk about the high-risk readmission program, and he's done a lot of work in this area. He is fairly sure he's one of the world's leading experts on the high-risk readmission program in the United States, and so we're super lucky to have him. Ankur, I found out that Ankur and I almost overlapped. Ankur was born in Rohtak, Haryana. He went to medical school in one of the most elite places in India, the All India Institute of Medical Sciences in Delhi. From there, he came to Temple, and we just missed each other at Temple. He was at Temple from 2008 to 2011, doing his internal medicine residency. I had left Temple in 2006, the end of 2006. So we just missed each other there. We both should give a shout out to Dr. Moyer, our wonderful program director, who now heads the American College of Physicians. From there, Ankur went to do cardiology at the University of Alabama, UAB, and from 2011 to 2015, he then decided to get into clinical research and went to the Brigham and was there for 3 years, and now has moved on to start his interventional cardiology fellowship at UT Southwestern Dallas. So, Ankur, welcome.
Thank you so much. Thank you for the very kind introduction. And I'm definitely not anywhere close to being an expert on readmissions. There are definitely a lot more people who have dedicated their lives and careers to heart failure admission and other readmissions reduction. And definitely Dr. Moyer has a great influence on me, as both personally and professionally. So I'm very indebted to Dr. Moyer for that. And thank you for having me on the program.
Yeah, sure. So we'll get right into it. So the high-risk readmissions program, by the way, you're incredibly modest, Ankur. You certainly have done some excellent work on the high-risk readmission programs, which we'll get into. And then the audience can decide whether you're an expert or not. The high-risk readmissions program passed under the Affordable Care Act of 2010. CMS, the Center for Medicare and Medicaid Services, initially targeted readmissions following hospitalizations for heart failure, for myocardial infarction, as well as for pneumonia. Now, this was all stick, no carrot. So there was a penalty for hospitals that had higher than expected readmission rates. So, for hospitals, this was a big deal. Up to 3% of a hospital's total Medicare admissions revenue was at stake. So it's not just that they were putting at stake the heart failure revenue; they were putting all of the Medicare revenue that hospitals were getting at stake. In 2017, 79% of hospitals were subject to high-risk readmissions program, to the penalty. Sorry, the HRRP penalty. And this accounted for about almost $500 million. So, Ankur, we were both kind of in the thick of things, in the trenches, in terms of trying to take care of heart failure patients when the HRRP came out. What was your first response when you heard about the program?
Right. So before I get into that, just although these are high risk readmissions in the sense that they're high risk of getting readmitted, but the actual program is actually Hospital Readmissions Reduction Program. Just as a minor correction to that. I've been following very closely when I came to US, the health policy, as Obama was running at that time to be president when I came here in 2008, and then as the focus shifted from pay for volume to pay for performance under his presidency. And so initially I was actually very excited about this because fee-for-service model promotes more high-volume care, which may or may not necessarily be high-quality care. So this, on theory, sounded really good. And as a resident taking care of these patients, I was very excited. But then when it actually hit the hospitals and hit us, I realized that, hey, it's not as all flowery as it sounded, especially given the pressure from the administrators that trickled down all the way to us, even up to residents and interns, to ER physicians, to heart failure physicians, to everybody. And the message was loud and clear, even though it was never said in those terms, is to not readmit those patients within 30 days and to try to keep them out. And I guess on day-to-day activities, we may not realize, but overall, I think it has negatively impacted some of the care for these patients, because sometimes the ER may not even call us to admit those patients anymore, that we used to get those calls. So sometimes as internal medicine or cardiologists, we may not even see those calls anymore to us. And then we realize that here outpatients were kept and they had ER visits.
Yeah, Ankur. So yeah, first of all, absolutely. I can't believe I goofed on that. I've been writing on this since for 3 years,
Right.
and yeah, no, obviously it's the hospital readmission reduction program, not the high risk.
Yeah, maybe it should have been called high risk. It sounds much better, actually, and more appropriate.
Yeah. No, I kind of, I think about it symbolically in the same way. It's, and that's one of my beefs with it. Before we get back to it, is that, I was all about this idea when Obama was running, and with the general themes and what was being said at the time, was that there's a massive amount of waste, and we have to figure out how to cut waste. And this way we can get all the nice things that we want, and not spend so much money, and we'll have more money for other things, and it'll be wonderful. And I realized, just like you did, as I was sitting there trying to take care of these patients and seeing how this was unfolding, was that the folks that were being targeted were the folks that were super high risk, and they were being targeted in a very, very granular way. These were folks that were targeted in a very blunt way, which essentially lumped everyone together. And I was appalled and aghast by it. So, I was seeing, just like you, I was seeing patients of mine that I'd been following for a very long time. There were tenuous patients who, would slip off and, eat one too many hot dogs at July 4th and come to the hospital. And, I would get a call from the patient's wife saying, he's here, he doesn't look good, his legs are swollen, he's not breathing very well, his oxygen levels are kind of low. I was like, oh my goodness, where are you? It's like, oh, we're in the ER, and we've been there for 24 hours. I was like, I haven't been called. And she was like, well, yes, that's why I'm calling you. I'm calling you because they want to send us home now. Yep. And I don't know if he's ready to go home. And then I would, rush over to the ER and say, what is going on here? Because it used to be, the standard was that if these patients these were sick patients with, EFs of 20-25% who were in with heart failure, like the automatic thing was, call somebody to admit them. We are not dealing with these patients here. And now all of a sudden you had this massive shift that I saw in terms of how the culture shifted. That's
exactly right. And I guess our experience is probably shared by many of the people in the front of the healthcare system, taking care of the patients.
Right. So some of the things that what can you go through some of the specific issues in terms of what the why it is, or how it is the hospital response was, why did the HRRP program fail? What were the problems that you saw with it?
Right. So I think there are several problems with it. One is in its design itself. So the readmission reduction program initially targeted heart failure, pneumonia, and acute myocardial infarction, the three most common causes of readmissions among Medicare beneficiaries in the US. And the way the program is designed is to penalize the hospitals if they have higher readmission rates than national average. And the part of this was risk adjustment. So the two problems are right here. So one is risk adjustment. It's hard to risk adjust readmissions for such sick populations based on administrative coding alone. And on top of that, the CMS rulemaking and through the way the HRRP statistical methodology was designed, they decided to exclude socioeconomic status and race from the risk adjustment. The argument being that we do not want to lower the expectations or standards for those hospitals. So by including them, somehow we would lower that standards. So that was one problem, that risk adjustment was not adequate and may still not be adequate. And the other part is this national average thing, which is always a moving target. So even if the hospitals over time improve their readmissions, but if they still fall below the national average, they'll still get penalized. And there is no way to predict what's the next year's national averages. So the benchmark is hypothetical, unclear to hospitals where they need to go. And it's always a moving target. And they may improve their practices and still get penalized. And we are seeing that, as you said, in 2017, almost 80% of the hospitals were penalized under this program, which is amazing. I mean, what health policy program you expect to penalize 80% of all U.S. hospitals that have contract with Medicare?
So, wonderful, great answer there, with a lot of great stuff in there that I should unpack a bit, or highlight a bit, I should say. You bring up the fact that that these were this was data that was generated or based on risk, based on administrative claims data that was risk adjusted, correct? And over and over again, we've seen this in public reporting, we've seen it elsewhere as well. The big question is, are you adequately risk adjusting? And here you raise such an important point, is that they did not allow probably one of the most important risk factors, which is socioeconomic status, to be used, right?
Right.
And we talk all the time about the difficulties in appropriately risk adjusting, and certainly when you take socioeconomic status out of the mix, that is you really have to question any risk adjusting model that comes out of that. And then the other point that you bring out that's just fantastic is this benchmark. Like, what is the benchmark? And
Right.
the fact that you year to year, year over year, you're not sure what exactly you're comparing. So they have to come up with this national average. So obviously, when the game is rigged like that, it seems relatively obvious that what the folks are going to do is to try to game the metric, is to cheat in order to and game the system, and that's essentially what happened. So why don't you actually? And we've already touched on some of this, but what were some of the ways that you saw that the hospitals responded to this game that they were not going to win?
Right. So I think if you look at the data for the readmissions, one of the earliest NEJM paper from Zuckerman that came out that showed for all three conditions combined, the readmissions fell very quickly after the passage of the law from 2010 to 2012, even when the penalties were not enforced. And then from the Yale group, there are a couple of papers in Journal of American Medical Association showing essentially similar things for each individual condition. So it sounds all very successful that readmissions actually did go down, and the program is a success in achieving readmissions reduction. However, the one thing we did notice in those papers is that the reduction in readmissions was almost immediate as soon as the law was passed, and was very rapid decline. Now, having worked in healthcare, one thing we know for sure is that's probably one of the most difficult things to do. Is to keep heart failure patients out of the hospital. And so we were really surprised to see that somehow hospitals, after the passage of law, quickly figured out, what's causing their patients to get readmitted, then devised strategies, implemented all those strategies successfully, and had very quick results out of that. I mean, this is like almost a fairy tale that happened after the passage of the law in terms of readmission reductions. So we were really concerned that, are we seeing this readmission reduction? Is this artifactual or is this real? Given those concerns, and the actual concerns raised with the passage of the law were, will the hospitals increase their observation stays, which do not count towards readmissions? Will they actually prevent patients from getting readmitted with inappropriate ER triage strategies, as we mentioned? Or delay the readmissions beyond discharge day 30th, try to keep them in hold and manage them at home with increased diuretics or whatnot, and until it's beyond discharge day 30th. And then upcoding of their illnesses, other comorbidities that would decrease readmissions with risk adjustment. So all those were real concerns with this data, because it sounded too good to be true. In terms of readmissions.
Yeah. So as you're bringing up, 30-day readmission rates did decline, right? From 23% to 21% from 2008 to 2014. There was a 9% relative reduction in readmits. But as you know, as you're saying, the way hospitals went about doing this is not necessarily what we thought was going to happen. Because what we thought was going to happen is that, look, there's a percentage of patients that get readmitted to the hospital that shouldn't be getting readmitted to the hospital, right? The estimates were that 25%, exactly. I don't know how they came up with it, but they came up with this estimate that 1 out of 4 patients were getting readmitted. If they just had the right care in terms of transitions, would be better, would not have to come back. Pharmacists calling patients, nurses calling patients at home, daily waits, etc. When patients went home, all those things were thought to hopefully we're going to cut out some percentage of folks that would need to be readmitted. But it turns out that that's not while that's some portion of patients. The way we went about applying this was probably not the wisest way. And so the real way, yes, hospitals did all those things which were good, but the real way hospitals got these impressive fairy tale like numbers was using ob status, right? So observation status is not considered an admission. It's something that's under the ER, which is partly why you and I now weren't seeing these patients, right?
Right.
Now they would set up observation units, and the observation units were the same floor that used to be an inpatient unit, but now they called it an observation unit, because they were never truly admitted to an inpatient service, a medical service, a cardiology service, or sometimes they're even admitted to a medical cardiology service, but they're still left as observation status. Mm-hmm. And there's the clear data that came out was that the rate of ob status, exploded after the HRRP program came out. So you were effectively gaming the system by saying, all right, these aren't inpatients, these are OBS patients. And by the way, the OBS patients don't get the same care as if you admit them to a heart failure service, correct?
Absolutely.
Where, you have a heart failure attending who has 30 years of experience. Now you have an ER attending who, not trying to start a war with my ER colleagues, but they perhaps, managing a sick heart failure patient, is not necessarily their area of expertise.
And I have a bigger issue with the observation stays than inpatients.
Yeah.
And the issue is not just the care that the patient gets.
Yeah.
But the issue is that the way the Medicare, is saving money through these readmission penalties is ultimately getting transmitted to our Medicare patients because of observation status. Because as you know, under observation status, the patients are actually billed as outpatients, which is much higher billing and co-payments for Medicare Part B than for Medicare Part A if they were inpatient, which is mostly covered. So
Right.
now, because the hospitals are admitting them as observation stays, patients' bills are higher.
Right. My understand. Right. Exactly. So when you build through Part B, this outpatient status, then patients now have a responsibility for about 20-25% of that of that
Right.
of that visit, and unless they have some supplemental plan or whatnot. So
Yeah.
no, we're transferring. We're also transferring costs to the patient. So multiple issues. Um, did um, did heart failure patients uh, is the data clear on whether heart failure patients benefited from this or not?
No, I guess it depends on what how you define benefit as. Yes, the CMS benefited from it by saving over $500 million last year, and we were saying money saved is money earned, so it's essentially a CMS revenue. Whether the heart failure patients benefited is really a big unknown, and some of the work in the literature has suggested that likely not. In fact, the concern is that they may have been harmed. So, as I mentioned, and as you mentioned as well, the purported number was about 25% of heart failure readmissions were preventable, but only about 9% relative reduction was achieved with this program. And some of that is through other gaming mechanisms that we just discussed. Um, and most of it has now plateaued. So the gains were in first couple of years of the program, and now it's essentially a flat, or close to flat line for the reduction in readmissions. And second, this has been unfortunately written in literature now so many times that most patients would prefer getting readmitted than dying. And we are seeing the signal of excessive death. So I wouldn't necessarily call, even if there is a true reduction in readmissions of some percentage point, as a benefit to the patient. And lastly, it's completely unknown if they actually benefited in other ways in terms of quality of life. Which actually, truly matters to the patients as opposed to readmission metric of, a couple of days in the hospital, which I agree is bad. If we can avoid it, we should avoid it. I'm not saying that they should come to hospital, and I'm sure you are not saying that.
Yeah.
But if coming to hospital prevents them from dying or improve their quality of life for next, 27 days of the month, then maybe yes, they should,
Right.
or we should figure out other ways of doing that. But in my opinion, this program has not benefited our patients.
Yeah. So and again, this is something that is reasonably obvious to the guy like me who's working in the trenches taking care of patients. We needed, of course, you to kind of provide the ammunition in the form of data to really get this out there, and that's what you and your group have done, and you've authored some of the major papers on this, right? And you've showed that, and others have, I don't think this is a matter of debate, that yes, the 30-day readmission rate did decline, but mortality has increased, right?
It is a matter of debate, unfortunately.
Well, it may be. Let me rephrase. It may be a matter of debate whether or not HRRP has caused
Right.
mortality increase, but I don't think there's much debate from anyone saying that mortality for heart failure is not going up. The question is why
That is correct.
up, right?
That's exactly right.
Yeah. So risk-adjusted mortality has gone up, 7.2 up to 8.6% in one study. It all mirrors that. And this is a reversal of a long trend of decreasing mortality in heart failure patients, correct? And when you look at 1-year mortality, we're talking 30-day mortality, but about 7 to 8.6%. 1-year mortality has gone up even more, from 31% to 36%. Right. Your group showed this. Now, let me hope you correct me. The Dharmarajan group, right? Dharmarajan, Kara, and Krumholtz. That's the group at Yale. Am I getting that right?
Yes, Dr. Krumholtz's group, and Kira is currently actually a fellow at UT Southwestern, but he's working with Dr. Krumholtz. So, okay. But it's mostly Yale's group data. Yes.
Right. Okay. So, so everyone has shown this increased mortality, and the question is why? And of course, a lot of us who are sitting around in the field and seeing what's going on in terms of what's fundamentally changed in terms of the culture shift. I mean, you can argue with us, but you certainly can't blame us too much for our prior being, well, it seems like this is the cause of it, because this is the major culture shift that's happened in terms of heart failure. In terms of heart failure management is how we're dealing with these folks. Now, the Krumholtz group has a very different view. Can you articulate some of their points in terms of and also, if you do know, what is Dr. Krumholtz's where does his interest in this come from?
So as far as I understand that their group was the one who developed the HRRP statistical methodology for readmission reduction for CMS, for the readmission reduction program, penalty formula and how the risk adjustment will be done. So they have been involved in this work for very long time, even long before the law was passed. Oh, yeah. And I truly believe that it's extremely well-intentioned work. They're all very nice people, and I have great respect for all of them. But I think that sometimes well-intentioned activities may not come out well, or may not turn out well, and that's what we are finding. So there's a lot of intellectual capital from their group, in addition to whatever financial contract they have with the CMS to develop and maintain and oversee this methodology. And as I believe, as humans, it's hard to dissociate that bias. That's why we have all these independent experts for clinical trials for drugs and devices, independent from industry to develop those. So I see this as equivalent to that. Given that there's a lot of intellectual and financial interest from their group, that we do need some independent evaluations, while of course having them in the midst of discussion, because they are really truly the experts who spend a lot of years of their lives on reading, studying, and developing this. One of the points, a couple of points their group make, the most recent papers from there that just got published in JAMA Network Open, I think last month, was that they're saying that the mortality is rising, the post-discharge mortality in heart failure is rising. It didn't come out significant compared to the pre-HRRP period, but it was rising. And they're blaming it on that the rise started prior to the HRRP passage. And if you see other papers, some papers have suggested no, it didn't. It really, truly was declining even in 2009 or 10. And then some suggest that it started rising maybe around 2008-9 when the risk-adjusted readmission rates were made publicly available by a public reporting mandate. So whatever it is, it may have started a little earlier or may not. But what we are seeing is that with this entering of this program, it has changed the slope of decline of the heart failure mortality to flattening them and increasing it over time. But their group is saying that no, this all started prior to the HRRP. And the other, I think the point they had raised with our data was because we use Get With The Guidelines heart failure registry data, which is a voluntary program, so only a certain percentage of US hospitals participate in it. And they raised the issue of generalizability of our findings to the entire Medicare population, or all the hospitals that cover the Medicare. And we believe that both those points may have merit, although the data doesn't suggest that, because the Get With The Guideline registry data has been shown to be nationally representative in other prior work. And we are finding what we found in our paper of rising mortality was shown in their own papers for rising mortality. And if one could argue about a p-value of 0.04 or p-value of 0.11 being significant or not significant, but if the concern is of such substantial patient harm, that should be taken seriously. especially from a program that is mainly to save money for the government, as opposed to truly targeting improvement in quality of care. Similarly, for drugs and devices, if there's a signal of substantial harm, you would not approve that or monitor it extremely closely, as opposed to saying that, hey, there's no signal. So that's our biggest issue, is that we don't see that level of seriousness from the groups, and honestly from CMS, from the most recent MedPAC evaluation of this program earlier this year, that they're actually taking it very seriously.
Yeah.
So our work on this will continue until we find some more evidence either way, whether refuting our prior papers or substantiating it, so that there's more clarity on what is going on here.
Yeah. Yeah. So there's a lot of talk about there's a ton of talk about conflict of interest. I mean, every time I eat a lunch from someone, or I get there are no more pens.
Right.
We're reporting it, and dollars for docs and ProPublica, and there's tons of financial COI. New York Times, Dr. Balsara, esteemed researcher, didn't report something, and now is resigned from Sloan Kettering.
Right.
I think, and again, this doesn't mean to, as you're saying, these are incredibly bright people, who are well-meaning, they're well-intentioned, they're trying to solve some very big problems. They're incredibly, smart and have great infrastructures that are behind them. But again, we have to separate out, criticizing the work versus criticizing the actual people. But and in this case, it has to be said, and this is something that I don't see ever mentioned. We talk about COI reporting. Why is it not? I mean, it is a little hard to get to. I mean, everyone who's in the community kind of knows, but if you're like some random methodologist who's reading it, say you're like a
right.
School of Public Health first year who's reading these data, you don't know that Dr. Krumholtz and his group are essentially the folks that are behind the inception of the HRRP program, right?
Right.
When CMS had this charge to say, look, we're spending way too much money on healthcare. How do we figure this out? They went to some very smart people. Dr. Krumholtz was one of those very smart people. And Dr. Krumholtz says, hey, look, this is something that we can go after, and we can use the tools that I give you in terms of risk adjustment to decide on all these things. I mean, they needed a mechanism, a framework to try to figure out how to pay for value, and try to improve care for patients at the same time, save money. And so it needs to be, I think it's a very important point to bring out that there's a schism, if you will, between I think a lot of the data is from cardiologists like you who show the increased mortality and point to the fact that the HRRP program may be what's responsible, and the Krumholtz group. And the Krumholtz group has written multiple editorials saying that we don't think the HRRP program is responsible for X, Y, and Z reasons. But again, they have a vested interest, right? These are the folks that came up with this. They essentially gave it to the government to implement, and it looks bad if the program that you gave has actually resulted in increased mortality. So it's an important point that I think is not brought up much in terms of
I'm sorry. Yeah, I was just going to say quickly that it's also much more generalizable in health policy. The conflict of interest we don't think about in health policy. World, and I think that is what we are seeing HRRP as an example of. As opposed to, we are always looking for, hey, is this trial funded by industry? How much control they had.
Right.
The endpoints committee is looking at it. The DSB is looking at it. Everybody's looking at it. Whereas in health policy, nobody actually looks at it.
Right.
I think this is just an example of that. Nothing specific to HRRP or this group.
Yeah. So this idea that, like, if you're a cardiologist, you're automatically biased, but if you're a methodologist and you're a public health guy, you're not biased.
Exactly.
Utterly untrue.
Right.
We just have different biases, and I cannot understand why folks don't easily see this. The other aspects in terms of the specifics, right, of why the Krumholtz group does not believe that the HRP program is responsible for the increased mortality is as they point to the fact that, hey, look, HRP wasn't just heart failure, it was AMI, it was pneumonia. Are we seeing increased mortality with AMI and pneumonia? We are not, correct?
Right.
And they say, look, this suggests that everything is not linked. But again, for folks like us who are sitting there taking care of these folks, we recognize heart failure patients as being much, much sicker than the average patient who hits the door with pneumonia, or the average patient who hits the door with an acute MI. So one of the lessons I would hope folks learn from this, and it's a point that I've tried to make before, is that there's a lot of waste in our system, and we need to try to get rid of it. But you have to be very, very careful about trying to get savings from folks that are high risk, high mortality.
Absolutely.
Because you are going to run a very high risk if you try to reduce care. If you try to, these patients that come in crashing, they're crashing on ECMO, you're doing all sorts of, high risk type of stuff. They have incredibly high mortality. And yes, they cost a lot. And yes, the desire from the essentially the accountants in healthcare is to look at those places and say, hey, let's go after those folks. And we as physicians, I think, and that's our job as patient advocates and doctors that take care of these very sick patients, to say, look, you should be very careful about trying to cut in this place, right? If you want to cut, I would suggest, if you want to go cut things and not have a big time and not see a big time, not move the needle much in terms of mortality or quality, primary care is, certain primary care things, not all primary care. I'm going to get hate mail from family practice doctors, but looking at certain places in primary care, because they have, they're much lower morbidity in terms of changing process in terms of how you do things there. It is obviously going to maybe higher yield in terms of cutting costs, but not moving the needle much in terms of mortality outcomes, etc.
Yeah, and this is a critical point I think you bring in. It's somewhat paradoxical. So for relatively low risk populations, for example, there are trials for prostate cancer screening, for breast cancer screening, that we are targeting overall low risk.
Right.
But we are doing trials for that. But
Right.
when we are targeting high risk, people sitting in their rooms are making decisions and implement nationwide policies that have major implications and cost implications.
Right.
And there are no trials for that. And this is really paradoxical that we are happy to target high risk population without actually proving that it works.
Right. Now there was a great point. There was a paper recently by the Krumholtz group, by Kara Dharmarajan and Krumholtz, in JAMA Network Open, where it looked at the association of Hospital Readmission Reduction Program with mortality during after hospitalization for AMI, heart failure, pneumonia, and they concluded that among Medicare beneficiaries, there's no evidence for an increase in hospital or post-discharge mortality associated with HRP announcement. You had some specific comments on that paper. And I only bring it up, and I don't mean to belabor the point, and we've talked a lot about differences in, why it is the different groups are coming up with different things. But this touches on something important. Meaning, is it possible to, in an era of methodological complexity, increasing methodological complexity that we're seeing in terms of analyses of these, especially of these non-randomized control trials, that you have the same data set looked at by different folks, and you get very, very different. You come to different conclusions. So I thought it was interesting that you brought up some very unique things about this paper, and I wondered if you would go into what your thoughts were on that paper.
Right. So this is absolutely right. We know that if you give data set to two different statisticians or clinicians, they may analyze it differently and may end up with different conclusions. There may be minor differences in how the hypothesis is generated. But here in this particular paper, the most surprising to me was how the results were interpreted in the paper. Mm-hmm. Especially given the primary aim of the paper was to elucidate any signal of harm.
So with that mindset that we want to know if there is really any signal of harm from this policy. And what they found was is that the heart failure inpatient mortality after the law was passed, as we discussed, it was declining before that for a decade, and then it actually flattened after the law was passed for some time. And they never, and this was statistically significant as well in their paper, the change in slope of the declining heart failure mortality that actually flattened. So in absolute terms, even though the mortality didn't increase in their paper for heart failure, but in relative terms, there was an increase in mortality because it didn't decline as much as one would expect. But this was actually never brought out in the paper and was, in fact, somewhat hidden in the paper in the sense that they said there was no change in mortality. Even though that was not the primary aim of the primary aim of the paper was looking at the slopes of the interrupted time series analysis. So if somebody is really looking for the signal of harm and you see this, whether or not you attribute it to the HRRP is a different matter. But if you see this, it needs to be brought out and maybe need to be more, elucidated as to why this may have happened, whether or not related to HRRP. But this was never even brought up. The other thing was the post-discharge mortality. So this was, I was talking about earlier, inpatient mortality or in-hospital mortality. But even the post-discharge mortality, as I mentioned earlier, was rising, but the p-value was 0.11. Now, I'm not sure if we really need to judge the signal of harm by a p-value of 0.05, especially when there are other multiple studies showing that this may be real.
Right.
So, their data was administrative. Our data was using clinical risk adjustment from Get With The Guidelines, which is much more robust in terms of risk adjustment. And we are seeing this rise in mortality much more than it was prior to the HRRP. So I think I see it as a duty of the authors who are looking for that signal is to say, hey, we see this, it doesn't meet statistical significance, but we are very concerned about this. So I think those were the points that I was trying to make about the paper. And they were purely based on the interpretation, truly believing their analysis, but purely based upon the interpretation of their results. But as you said, that there must be other independent investigations into it because then there are tons of statistical decisions you make along the way that may or may not ever truly, stand out in a paper. But as an independent expert, you may not be biased in making those decisions, and hopefully other groups could look into this and see what they find.
Excellent point. Now, Rohan Kara is, is part of the Crumholz group. Am I getting this right? Are you both at UT Southwestern?
That's exactly right. I'm the interventional fellow, and he's a general cardiology fellow here.
So what happens? Do you guys do arm wrestling every day when you get?
Yeah, we are really good friends. We are actually both from Ames. He was my junior in Ames. And we really like each other and have a good time together. And sometimes we do arm wrestle.
Wow, what a great story. But no, excellent points, Ankur. Well, hopefully we'll bring this out in the future as well. For guys like me that are lowly clinicians, I took a very different track from Temple than you did. You spent 3 years. 3 years, correct? 3 years doing clinical research. Is that right?
Right.
And you did
actually 4 years because I was at UB during my general fellowship. I stayed an extra year doing research there.
Wow! And so, did you get a master's or something in epidemiology, or what did you?
Yeah, right. So I did a PhD. It was interdisciplinary. So I did in statistics and computational fluid dynamics. That's my second, clinical interest is in coronary fluid dynamics.
Oh wow, wonderful. Well, for a guy who did not spend 3 or 4 years doing a PhD, finishing a PhD in statistics, it can be it makes some of the when we see some of this going on from the outside in terms of how should I put it in a way that is I feel like there's a lot of folks that look to EBM as giving us certain answers, and I think we're, I don't know. It's not as, it's certainly not as simple as that, and unfortunately, for a lot of clinicians, I can speak for. You have a sense that something's not right here, that this program isn't correct. But that we can see it in terms of what's happening to our patients. But luckily in this case, we have someone like you who's able to actually generate data and kind of be on a level playing field with folks to kind of take our side. But I can tell you there's many things where there aren't interested groups. And so you have essentially one side with an agenda that is generating lots and lots of evidence. And the folks that are making policy are looking to these folks, are looking to come up with policy changes in terms of guiding policy moving forward. And it's frustrating in terms of in seeing this, because I wouldn't have been able to write or do any of the analyses that you've done. I'm glad that you did do that in this particular case, and we have something some legs to stand on. But I can tell you there's so much in clinical medicine that we see that unfortunately doesn't have someone like you doing this type of stuff. So it's great.
That's exactly right. Why I chose to spend all this years in research, because I was so frustrated doing clinical medicine and not able to answer some of those questions that were constantly in my mind when I was practicing.
Yeah.
And we definitely, it's very encouraging. When I was at School of Public Health during my time at Brigham, there are lots of clinicians now pursuing formal training in clinical research in one way or the other. And hopefully, over next generation of clinicians, this may change and be more critical of the research that we see.
Yeah. Well, wonderful. So we'll end on an optimistic note that things will be changing for the better.
Right.
All right, wonderful. Ankur, thanks so much for spending the time with us. I know we ran a little over, but it was a great conversation. Really appreciate you coming on.
Same here. Thank you so much for inviting. Appreciate it.
Alrighty.